Thank you, Mr. Chairman, and I'd like first to thank the organizing committee for giving me the opportunity. And as per the title given to me, we'll be talking about updates in the management of rectal cancer. So to start with, it's basic facts telling us that the second and third most common cancer in females and males, 1.5 million new cases and almost 700,000 deaths. This is actually the American statistics with lowest rates in Africa, South, Central Asia. What do we know? To start with, before we start anything, that the surgery is the cornerstone in management. However, we are trying to improve the results of the surgical outcome, but this is nothing to forget about. What do we have? We have patients who experience local recurrence after surgery alone, as you can see in the right-sided column. Something like anywhere between 20 and 40% would suffer from recurrence having surgery alone. But you can reduce that by post-operative radiotherapy, something like by 50%, which is very important. So there is a role for radiotherapy, and we'll discuss pre-operative or post-operative. However, it's very important to go in conjunction with the surgical approach. We don't need radiotherapy and even chemotherapy or systemic therapy in early stage disease. So something like T1, T2, N0 surgical treatment is the only treatment needed with good follow-up thereafter. However, when we come to more locally advanced disease, I'm talking about T3 and T4 node-positive disease, we need proper evaluation. And the standard of care now is to properly evaluate this with an MRI in addition to a rectal endoscopic ultrasound, rectal ultrasound. It's very important to get the information provided from this stage of critical information. The likelihood of achieving a complete resection are zero. The likelihood of sparing the rectal sphincter and thereby maintaining fecal continence. As early as the year 1932, we've already known Dukes, one of the very early physicians that dealt with rectal carcinoma and colon cancer, with the very famous Duke classification system goes into A, B, C, and D, which is nowadays 1, 2, 3, and 4 by the TNM and the AGCC staging system. This is a very nice paper published in the Journal of Clinical Oncology talking about preoperative magnetic resonance imaging, which aim to assess the circumferential resection margin, and that predicts disease-free survival and local recurrence with a 5-year follow-up. And you clearly can see. Anyway, أنا متأسف معلش. Okay, if you see these three curves with different out points in the very high left-sided, the overall survival, disease-free survival, and the incidence of local recurrence, you can see that with good assessment of the circumferential resection margin, you can achieve good data and achieve good. And this technique can be reproduced accurately in multiple centers to predict curative resection. So this is very important, and this is a joint work between the surgeon, the oncologist, and the radiologist and the pathologist. Actually, it's always has to be an MDT approach. Now, this is a very important thing that we have to carry out in our society, like again, in an MDT form, like the surgeons, like oncologists, pathologists, the so-called auditing. And by auditing, you can improve your results. And this is actually a very good piece of data coming from the Dutch surgical colorectal audit program that looked into more than 13,000 patients, and that actually went down to the incidence of recurrence by more than half. And the conclusion actually is already in that blue circle telling us that after introduction of this auditing system, a dramatic improvement in the circumferential resection margin reporting and major decrease of the CRM involvement after rectal cancer surgery have occurred. I guess this is something that's not expensive, that's doable, and I guess that we can do in our society, and again, between the surgeons, oncologists, pathologists, and radiologists. So radiotherapy and surgical resection margin are the standard of care in any locally advanced disease by the T category or the node-positive status. I guess this is a very basic stuff for our dear surgical colleagues. Total mesorectal excision, just a picture. What about neoadjuvant therapy? Well, what do we aim by applying neoadjuvant therapy for patients with cancer rectum? We are aiming at optimizing the disease-free survival and overall survival, hopefully, minimize the toxicity from radiotherapy and chemotherapy, and eliminating local recurrence, which is a very ominous bother to our patients. So early on, the German study group looked into the pre or post-operative radiotherapy. And you can see clearly on the right-hand side, it's went down from 13% to 6% if you give pre-operative radiotherapy. So actually, the slide speaks on its own. Yes, this is the red one. What about preoperative multimodality therapy improving disease-free survival in patients with carcinoma of the rectum? This is the very famous landmark trial of the National Surgical Adjuvant Breast and Bowel Group, R03. Again, these are the disposition of the treatment of the patients where patients with T3 and T4 or node-positive disease were included, a dose of 45 gray in 25 fractions. Surgery was done something like on average after 8 weeks of the radiotherapy, which is the standard of care. And the primary endpoints were disease-free survival and overall survival. This is again the disposition of the patients, and clearly with the hazard ratio 0.6 and 0.69, you can see in terms of disease-free survival in the upper part and the lower part of overall survival, there is an improvement of the preoperative radiochemotherapy followed by surgery in something like 6 to 8 weeks after this type of treatment. Now, a little bit of details about the preoperative treatment, where the German, French, and ARTC trials looked actually very carefully in the instance of local recurrence and compared pre- and post-operative radiotherapy, and you can clearly see a significant improvement by the use of preoperative radiotherapy rather than the post-operative radiotherapy. However, in the lower part of the slide, you can see that there was no improvement in overall survival. So that's something to keep in mind. There was an improvement in the local control, but not in overall survival. One other form to give the radiotherapy, which was very liked actually in the 90s and the early 2000s, is to give a short course of radiotherapy, the so-called 5x5. In 5 days, you finish the radiotherapy course, and usually we did practice that in Alexandria. The patient finishes his treatment on Thursday. On Saturday, he goes to the OR to do the surgery. And this is still approved, by the way. However, it has certain indications. Not every single patient can go for that. And the Swedish, the Dutch trial, British trial, almost always tell us that this is also beneficial. However, with quite a difference between the 5 usual 5 weeks dose with chemotherapy. So these are the two methodologies, a short 5x5 or 45 and 25, like 5 weeks combined with chemotherapy. You see that the only 3 upper factors looked at are the only significant ones. The acute toxicity, it's definitely more in the 5 weeks. However, the PCR is 16-1, which is something to look at. The PCR, which is very important surrogate in treating those patients with neoadjuvant therapy. And it means a lot to those patients, complete pathological response. So actually, the shorter course gives you little toxicity, but it's less efficacious as per the PCR rate and the CRM positivity. That the circumferential resection margin is positive in higher number in the shorter course than the longer course. Again, this is more or less repeating the same data in another trial, the trans-Tasman trial, showing almost the same piece of data, which is very assuring that you can reproduce the data. So we have less toxicity. The patient is very convenient. You can finish his radiotherapy treatment in 5 fractions. However, it's more better for him in terms of response and downstaging and achieving complete pathological response with the price of paying some more complications in terms of mucositis. So this is actually where the European model of stratification did. They stratify patients into 3 main categories: the lower risk patients, the intermediate risk, and the high risk. The high risk should go definitely for the longer radiotherapy chemotherapy course, and the lower will not go into any of this radiochemotherapy treatment, will go straight ahead to surgery. And in between, you can apply either way, the 5x5 or the longer radiotherapy course. So where are we now? The NCCN guidelines, rectal cancer, this is a version of 2016. It's already been updated, but nothing much actually. It recommends that with the ASTRO, the American Society of Therapeutic Radiation Oncology, as per the keeping the high risk definitely for the longer duration course, and maybe for the convenience of the patient, you can go for the 5x5 if you have a less advanced disease. Now, one very important question to us as oncologists, which makes a lot of difference because that question was asked so many times: do we always need chemotherapy in the combined approach? Yes. Combined neoadjuvant therapy means radio and chemotherapy. And you can see these are 4 very big trials telling us the difference if you use radiotherapy alone or radiochemotherapy. And the results are quite higher if you use radiochemotherapy in terms of PCR and the 5-year rate of local recurrence. You can see that in the red columns. Okay? So what type of chemotherapy? We have tried many, but basically it's 5-FU, and more convenient to the patient is the capecitabine, which is Xeloda tablets that the patient can have either on 5 daily during the radiotherapy course, and sometimes you can have it during the weekend, the 2 days off from the radiotherapy. So when oxaliplatin was added, there was no difference whatsoever. It did not improve the outcome. Again, when other targeted therapies like the EGFR, anti-VEGF were added, there was no difference whatsoever in terms of response and treatment outcomes. So the standard of care is the application of radiotherapy with oral Xeloda or capecitabine, which is a 5-FU therapy. So these are the indications. I guess I mentioned them more than once during my talk. Maybe more or less to locally advanced stage disease, node-positive disease, and these are the treatment outcomes. So what do we expect from the treatment outcomes? Either on the left-hand side, you can achieve a complete pathological response, and this can only be done after you do surgery. You can never evaluate a patient with pathological response unless he does surgery. On the right-hand side, this is the complete clinical response, which you depend on your clinical examination and the radiological examination. But it's not always a complete pathological response. You have to be very careful about that. And actually, this is the outcome in relation to PCR from the German trial, more or less repeating the same data I was talking about in figure A, B, and C, and the upper and the lower part. And this is actually impact of pathological CR, but PCR is a very important surrogate of the treatment outcome in those patients. It means a lot, and a huge difference between the patients who achieve complete pathological CR response as opposed to the patients who do not achieve complete pathological response. Again, in terms of local recurrence, disease-free survival, and overall survival. Now the question comes actually that is a little bit itchy to almost all of us. Can we avoid or skip surgery? I don't think so, by the way. But I mean, there are some good credible researchers that are looking into that. And unfortunately, we almost always have this problem with our patients. When they come to start with, and you tell them that you will have surgery 8 weeks or so after the radiotherapy, and they come after they finish the radiotherapy in the first visit to the oncology clinic, and they have no complaints and they're fine. So what about skipping surgery, which is not true, which is not right, in my books, at least for the time being. However, we have some data, and if you want to do that, you have to do very good surveillance by digital rectal examination, repeated endoscopic rectal ultrasound, and the timing of assessment has to be carefully taken off, tumor markers. I mean, this is a very tedious procedure. It's not that simple to put a patient on follow-up and not doing surgery. We have data, yes, we have data, and the data came actually, again, from the Journal of Clinical Oncology with the title, Can Surgery Be Avoided After Preoperative Chemoradiation for Rectal Cancer? And these are the very famous data by Hapar Gama. Hapar Gama is a Brazilian surgeon. She's a lady, by the way. And also data coming from the Mass General Hospital in Boston, telling us that there might be some patients which we cannot identify 100% by accuracy that can be spared the surgery and go into a tedious follow-up. But again, I will leave that to discussion because I'm not for that, by the way. I still keep asking my patients to do the surgical resection after that. So there may be patients with a PCR after neoadjuvant therapy who may be candidates for a watch and wait approach, thus avoiding surgery, which is the subject of current clinical investigation. So it's not the standard of care, at least in my own books. I don't know about the audience or the chairpersons. You have to be very careful, and almost always, complete pathological response does not mean that the patient has already, complete clinical response does not mean that this is complete pathological response, because there might be disease still left and not been identified by your clinical examination nor by the radiological examination. What about neoadjuvant therapy? I mean, don't want to get you into details. This is more or less one way or another to do our treatment preoperatively by adding more chemotherapy, which is the so-called total neoadjuvant. And we're still looking into that, but really some patients with a very locally advanced disease really need that. And the art of the day is to do the radical resection remains the cornerstone in the management regardless of the achieved response. I hope this message stays especially in the minds of my junior colleagues. This is another way or another. Don't go into details about the prospect trial, doing some different chemotherapy regimens. to examine the non-inferiority, and that was non-inferior by giving more chemotherapy to the standard of care therapy. And this is actually the outcome between the two regimens, telling us that you can safely use another regimen to get the same. So FOLFOX chemotherapy with selective use of 5-FU combined radiotherapy is non-inferior to 5-FU combined radiotherapy with chemotherapy for neoadjuvant treatment of locally advanced rectal cancer. Okay, and I would like to share with you a very last slide, and we're so proud of that. Actually, this is our department with the surgical department in Alexandria and the pathology that was already published actually in a very good journal, and we were looking to factors on the gene levels that would predict the better response to neoadjuvant therapy. As you can see, I will not go through details because I don't understand the whole details. This is our pathology colleagues who did something like methylation in 3 different genes, and you can see that أنا هخلص آخر slide. أنا آسف جدا. So age, gender, stage did not tell us exactly the response to neoadjuvant therapy would be. However, other factors like the differentiation, the pre-treatment CA level, distance from oinal verge, which is fine. The heart of our work was this slide actually. You can detect through different gene methylations, the so-called TEAP2E, MLH1, and microsatellite status with level of significance that those patients would respond to neoadjuvant. However, this work needs to be reproduced and validated. Thank you so much.